Welcome to this webinar from the Euroreference network about low prevalence disease. It's my pleasure to moderate this session. My name is Philippe Charon from Paris. It's my pleasure to co-moderate with Teresa Castiello from London, who is representative of the ESC Working Group on Myocardial Diseases. So the topic today we will discuss is about pregnancy in cardiomyopathies, which is an important issue, sometimes very difficult to deal with, and typically dealing with a multidisciplinary approach. So we have two experts today on board from Maastricht University Medical Center. So many thanks to them to be here. And probably, Teresa, I give you the words for the introduction of the first speaker.
Thank you very much, Philly. Thank you for the kind introduction. I'm delighted to be here. I'm delighted to introduce also Professor Stefan Heymans, which is works as well in the Heart Failure Association with me and the European Society of Cardiology. So it's a double pleasure to see him here. Before starting, probably a little bit of housekeeping, say that please to the audience, if they can put their questions into the chat box. We will have the first presentation with Professor Stefan Heymans, then we'll answer to your question, then we'll go ahead with the second presentation, question and discussion. So I don't want to take more time. So please, Stefan, I'm delighted to hear from you. Thank you.
Okay, thank you so much for the kind introduction and of course also for the kind invitation. You can see my slides, I suppose. That's fine, just to check. So indeed, I will give a talk on the impact of pregnancies on cardiomyopathies. First of all, the development of new onset peripartum cardiomyopathies, as well as what's the impact of a pregnancy on a patient with existing cardiomyopathy. So these are my conflicts of interest. So 10 years ago or 5 years ago, it would have been empty, but now with the increasing interest of industry in the field, it's now filled. So first of all, I will highlight the fact that, as you may know, that the development of a non-ischemic non-valvular cardiomyopathy, either being dilated, hypertrophic, or arrhythmogenic, often depends on the interaction between a certain genetic susceptibility as well as acquired factors or environmental factors, which is also the case in peripartum cardiomyopathy. So indeed, a lot of patients with cardiomyopathies initially present with unexplained heart failure or abort sudden death. The median age is around 50 years, going from young age, even from pediatric children up to 70, 80 years of age, either having a dilated phenotype, hypertrophic phenotype, or arrhythmogenic phenotype, which often goes along, at least in the desmosomal genes, with phases of acute myocarditis and probably also underlying chronic myocarditis. So as said, the cardiomyopathies are indeed the phenotype, the development, as well as the outcome of a cardiomyopathy, at least and for sure in dilated cardiomyopathy, is the result of the interaction between genetics, which can be monogenic, the classical gene mutations, but also these days can be a polygenic risk. That's also research in development, but also epigenetics. Think of histone modification, methylation, may determine a certain genetic susceptibility for a patient. And then often in interaction with, on top of a second hit, an acquired factor like viral myocarditis, autoimmune disease, toxic agents, chemotherapy, ethyl abuses, but also pregnancy, which is of course not a disease, but at least a disease modifier. So, and also comorbidities like hypertension and diabetes may also induce and facilitate the development of a cardiomyopathy. So that's why also in peripartum cardiomyopathy, new onset cardiomyopathy at the end of the pregnancy or during the first month of delivery, you will find literature where myocarditis viruses have been involved, where genetics have been involved, but also, of course, women that got chemotherapy before getting pregnant are also at a higher risk, together with pregnancies to develop a cardiomyopathy. So to summarize, so if you have a certain genetic susceptibility, acquired factors, let it be myocarditis, autoimmune disease, chemotherapy, toxic agents, and pregnancy as a disease modifier, mainly being a combination of volume overload, increase of cardiac output during pregnancy, as well as humoral and hormonal factors, will together facilitate the development of a cardiomyopathy. So this is also illustrated in this case of a new onset per definition, peripartum cardiomyopathy, where the pregnancy, the delivery has been a kind of disease modifier to unveil a certain genetic susceptibility. This lady, which I have seen a few years ago in the coronary care unit during one of my duties in the weekend, was a 36 years old woman who delivered from a baby and had signs and symptoms of congestive heart failure with a low ejection fraction and also atrial fibrillation. She told me that her mother was known with a gene mutation, being the titin truncating variant. And then, of course, we also screened her, tested her, and not surprisingly, she also had this titin truncating mutation. So which together then with the volume overload and the humoral and hormonal changes during pregnancy, the end of the pregnancy and the delivery would have facilitated at least either the development or the progression of the underlying cardiomyopathy. So quickly about titin. So as you may know, titin is the biggest protein, biggest gene in our body. It's part of the sarcomere in the cardiomyocyte. And it has been proven that truncating mutations in the A band are clearly pathogenic. So it's the most prevalent, likely pathogenic or pathogenic gene variant in DCM. It's responsible for approximately 1/3 of all gene mutation-related cardiomyopathies, at least in dilated cardiomyopathy, and 10% of all DCM or non-dilated left ventricular cardiomyopathy patients carry this pathogenic gene variant, in contrast to a very low percentage, but still quite prevalent gene variant in healthy controls. So that's why, not surprising, the first publication in the New England, which was led by the group of James Ware in London, was about peripartum cardiomyopathy, where they could see that, I don't know the correct percentage anymore, but about 10% of patients with peripartum cardiomyopathy carried a gene mutation, mostly in the titin gene, but also in other DCM sarcomeric genes related genes. And then increasingly new literature came up confirming that titin is a kind of genetic susceptibility, which together with acquired factors like alcohol, chemotherapy, cancer treatment, but also acute myocarditis, and even as recently published also by Job, systemic diseases can, together with a certain genetic susceptibility, lead to a cardiomyopathy. So that's why 8 to 15% of these acquired cardiomyopathy patients, including pregnancy-related cardiomyopathy, will carry these truncating variants. So again, so in literature, indeed, not only genetics has been involved in peripartum cardiomyopathy, but also myocarditis, a group in Berlin, I believe, also could demonstrate that viruses are more prevalent, that myocarditis could trigger this. And also, as said, patients that got chemotherapy before, together with pregnancy, are at a higher risk of developing a peripartum cardiomyopathy. So what's the prevalence? So it's estimated to 1 to 100 per 10,000 births. Of course, it may be underestimated because young adults often can cope with a cardiomyopathy for a long time without symptoms. So it might be an underestimation. Also, there are some regional differences all over the world. It's mostly, of course, per definition, peripartum cardiomyopathies at the end of pregnancy and the first months after delivery. So we will only know it if there are symptoms. ProBNP will confirm of course, the diagnosis of congestive heart failure. We need to do an ECG, echo, and also cardiac MRI is standard, of course, for non-ischemic cardiomyopathies at baseline. It's also safe in pregnant ladies. We need to go for genetic counseling and testing if she agrees. And then, of course, we also have to exclude other acquired factors, such as chemotherapy or viral myocarditis if there is a clinical suspicion, systemic disease, hypertension. Let's say the classical acquired factors that also may cause any type of non-ischemic cardiomyopathy. So what about the outcome? So approximately there is a 6% mortality at 6 months. That's what's being estimated in literature. More than 50% will have a persistent recovery within 3 years follow-up has been published. And of course, the medical treatment during pregnancy does not allow the use of ACE inhibitors or angiotensin receptor blockades or SGLT2 inhibitors, because that's say detrimental for the fetus, for the child, unborn child. Diuretics are allowed, thiazides mainly. Some say that less diuretics could also be used, at least for a short time period. Beta blockade, I think of mainly labetalol being preferred. Metoprolol also may be safe. And then, of course, we may consider bromocriptine. We know about this trial. Of course, it was not a randomized trial. They are working now on a placebo-controlled randomized trial. But there has been some indications that bromocriptine might also be beneficial. Of course, if it's after birth, after delivery, then of course we can go for classical heart failure therapy, at least if the woman would not lactate the child. So there has been this beautiful ESC position paper, so with a lot of nice figures, again, to repeat which kind of treatment you can give before delivery. So the diuretics, nitrates are safe, metoprolol, labetalol, thiazides are safe, whereas postpartum, you use the classical drugs, which you would also use in other patients. So what, of course, now I've been talking about peripartum cardiomyopathy, so kind of new onset or maybe unknown, but then unveiled cardiomyopathy. What about if you have a patient with pre-existing cardiomyopathy that would like to get pregnant? Of course, there is in general, there is an increased risk with pregnancy of progression of cardiac failure, mainly if there is pre-existing congestion, increased proBNP, or NIA class 3 symptoms. There is an increased risk then in this case of preterm labor and delivery as well. That's generally a description. And then as already said, some medications are contraindicated, whereas beta blockers and diuretics can be given during the whole pregnancy. So now I will focus for the last 5 minutes on the different types, phenotypes at least, of cardiomyopathies, the dilated, the hypertrophic, arrhythmogenic cardiomyopathies. So for the dilated cardiomyopathy, so honestly, of course, the literature of about pregnancy in pre-existing cardiomyopathy and the risk is not so extensive. So my own experience, at least in those patients which are asymptomatic and have an ejection fraction around 40% is good. I mean, they can cope easily with the pregnancy. But in general, literature indeed indicates that the main predictors of maternal mortality, but also of, let's say, congestive heart failure in the pregnant woman are at the presence of quite severe symptoms, low ejection fraction, diastolic dysfunction, also, of course, a sign of congestion, proBNP being increased, right ventricular failure, of course, is always bad, and atrial fibrillation, which is also a well-known classical risk factor for worse outcome in DCM patients. So however, if your patient is asymptomatic, proBNP would be low and ejection fraction is even above 40%, then there is a quite low risk. Of course, we advise close monitoring, so it's a multidisciplinary approach. This kind of pregnant woman with at least a cardiologist, a gynecologist, and a genetician. And so with the close monitoring of the heart and the baby, at least every trimester if low risk, and every month if there would be a high risk. In general, vaginal delivery is advised if possible, because then the risk of bleeding and also of thrombosis would be lower than with cesarean delivery. So what about hypertrophic cardiomyopathy? Also there is a risk in general of 25% of worsening of symptoms and complications. And the predictors are quite similar to those in dilated cardiomyopathy, so symptoms, congestion, but also, of course, in hypertrophic cardiomyopathy, the presence of a severe left ventricular outflow tract obstruction or arrhythmias. So if arrhythmias are present before the pregnancy, you have to monitor it closely during the pregnancy. And if there would be atrial fibrillation, anticoagulation, and if anticoagulation would be needed, then low molecular weight heparin are preferred, but also vitamin K antagonists can be considered. But that's, of course, in close interaction with the obstetrics. So also here, what is being advised in this 2021 paper is a close monitoring every trimester again if there is a low risk, and every month if there would be a higher risk. So finally, what about arrhythmogenic cardiomyopathy? So in arrhythmogenic cardiomyopathy, the classical one is those related to desmosomal gene mutations, whereas the non-classical is in the absence or is like the overlap with DCM, the phospholamban, the laminase C, RBM20. But in general, of course, it may be the leading cause of sudden cardiac death, but arrhythmogenic cardiomyopathy is not so prevalent in the general population. But in general, it's being described that pregnancy is well tolerated. So the risk of arrhythmias is not really increasing as compared to before pregnancy. And the predictors of arrhythmias is are the same as those in the general risk score, being existing ventricular tachycardia, syncope, the left ventricular involvement, which is also related to the desmosomal gene mutations, degree of right ventricular dysfunction, female sex. We know that desmosomal genes are more penetrant in female, and female also have a higher risk paradoxically in arrhythmogenic cardiomyopathies. And then, of course, the desmosomal genes are the ones with a higher risk of arrhythmias. So if AFib is present, again, anticoagulation. And again, as in DCM and HCM, close monitoring is required every trimester if low risk, every month if there would be a high risk. So I would like to conclude so with the main messages, so that the cause of a new onset peripartum cardiomyopathy can be genetic, so you need to go for genetic counseling and testing, but can also be a combination with acquired factors or acquired factors alone, such as systemic disease or previous chemotherapy. Hypertension can also be an additional factor, so you have to exclude those causes. Again, titin is the most prevalent one, but of course these days it's part of routine in genetic testing. Follow-up requires a multidisciplinary experienced team. There are not so many studies about pre-existing cardiomyopathy and pregnancy. I've seen there are some registries, so I hope there will be more registries about this. If there are little symptoms, few symptoms, or no symptoms, and ejection fraction is good and signs of congestions are absent, then pregnancy is well tolerated all over the spectrum of dilated hypertrophy or arrhythmogenic phenotype. However, if there are pre-existing symptoms and high proBNP, of course, first of all, you have to try to get rid of the symptoms and decrease the proBNP with medication. But of course, the risk of complications both for the woman, pregnant woman, as well for the unborn child would be higher if there is also low ejection fraction, if arrhythmias are present, right ventricular failure would be present, and in hypertrophic cardiomyopathy, if outflow tract obstruction would exist. So with that, I would like to end. Thank you for your attention and happy to take question, or would it be after the second presentation?
Teresa, we don't hear you.
I apologize. Thank you very much for this beautiful talk. I mean, there are not questions, so maybe I'll start with a couple, and hoping the audience will feel a bit warm up with it. So yes, we explained very nicely that, of course, when we see pericardial cardiomyopathy, as much as we see hypertensive or alcoholic, we know there is most likely a gene underneath. Will you do the DCM panel to any peripartum cardiomyopathy that you meet, or there is a bit of selection in where to proceed with the genetic panel?
Yes, of course, it will depend on the country where you have this patient. At least in our country, in the Netherlands, it's the genetic testing is part of routine diagnostics, and knowing that 10% would be at risk of having a genetic gene mutation, knowing that this gene mutation may impact the outcome, the treatment, the family members, arrhythmias, ICD implantation, yes, we would advise to go for genetic counseling and testing in every peripartum cardiomyopathy.
I think it does make totally sense. And of course, as you said, it really depends on the country, but in reality, we should all work towards that kind of goal. And so not yet questions. I'll do a second one then, if you don't mind.
No, of course.
So you mentioned about specific treatment and about the bromocriptine. Which are the selected patients where you would go for this treatment for? Because there is very little still, and perhaps it's done in very few centers. I mean, so what's your personal experience, if you have any?
No, not really. I mean, no, I don't have experience. I would not do it except if there would be, let's say, the last resort. But till now, with the pregnant women I had on outpatient clinics, I mean, with the classical heart failure treatment like beta blockade and diuretics if required, the patients were quite stable. So I mean, the study done was stimulating, but we need a placebo-controlled trial, and that's upcoming.
Thank you very much. There is actually a question from the audience. Thank you, from Ruth Biller. So is there a cutoff for right ventricular function where you would advise against pregnancy? Now, this colleague is actually asking specifically for RVC, but I suppose we can expand the question to other conditions. So would you rely, for instance, on the WHO modified classification, or it just way more selected patient by patient, if I may add?
Yes, but I mean, they haven't, of course, as we, determining right ventricular function is already not so easy to quantify it. There is no real cutoff for TAPSA or for MRI-guided ejection fraction. It's a general advice, like, of course, the worse the ejection fraction in the right ventricle, the higher the risk. Of course, if a person would like to become pregnant, we should explain the risk of the pregnancy and then closely monitor the patient, and if needed, treat with additional diuretics. But of course, you have to give an informed decision by the patient.
Indeed. There is one more question, actually. How long do you follow the peripartum cardiomyopathies?
Yes, I would do the similar follow-up as we would do in toxic cardiomyopathy or any genetic cardiomyopathy. I would, of course, after starting the optimal, the golden 4-5, you you have to follow them up at least for 1 year to see how cardiac function would recover. And then if cardiac function would be completely recovered after the first year, would be persistent recovery, then you could say, okay, every 2 years, 3 years, I would follow the patient back. If there would be a genetic susceptibility, then of course you need close monitoring. and lifelong, because we know that genetic cardiomyopathies may decline after an initial improvement, whereas in the gene-elusive patients, and if there would be a complete recovery and you would find a reversible cause like a myocarditis, then you would say, okay, maybe you stop after 2 or 3 years. So it depends on the cause and the underlying triggers.
Indeed. Thank you very much.
Welcome.
I think there are no more questions. So, Philip, I'll pass the screen on you. Thank you.
Thank you, Teresa. Thank you, Stefan. And I would just to add one thing about probably the importance of very early management during the pregnancy. As soon as possible, it's very important to better stratify the disease and the evolution. We know the WHO criteria for the stratification. Recently, we observed that the CARPREG-2 criteria were possibly more powerful in cardiomyopathies too, and importance for strong interactions with obstetrician, of course, very early too is very important.
Yeah, thank you very much for this addition.
So we can move to the second talk with, I am very happy to introduce Job Verdenschot, who will speak about the genetic aspect and the management of procreation issue, which is the second very important topic in this area. Thank you, Job.
Yes,
Good.
I think everything is working now. Perfect. Yes, thank you for the introduction. And I'm also very happy to give a talk about this topic here. So with my genetic background, I'm mostly focusing on, I rephrase the title a bit. Let me see, make it very short. You have a cardiomyopathy as a patient, how to get pregnant. So what are the options that you have if a genetic mutation is found to get pregnant and make sure that the genetic variant is not given to your offspring? So we know that the genetic background of a lot of cardiomyopathy is being unraveled. We know more and more about the genetic etiology. And as Professor Heijmans already showed, there's still a large part that is unknown of the genetic background. But establishing a monogenic cause, that will provide reproductive options for the patient. And that will be the main topic of my talk today. Because if we look at most of the genetic cardiomyopathies are autosomal dominant, which means that every child that you will get has a 50% chance of having the same genetic variant as the patient. However, estimating the risk of developing disease for these for offspring is way more difficult. It's way more complicated. That's because the genetic background of cardiomyopathy is way more complex than we at this moment perform in diagnostics. So we know that there is a 50% chance of offspring of inheriting the genetic susceptibility, but not everyone with the genetic susceptibility will eventually develop the disease. So the actual risk estimation is way more complex than we think. However, reproductive options are by now almost included in every cardiology guideline. So it's recommended to discuss this with the patient as soon as a genetic diagnosis is established. And therefore, it's important to understand the concept of reproductive options and the possibilities. And with possibilities, I have one slide on that. Is that the possibilities for reproductive options vary a lot per country. So it's still not really established. There are no guidelines how reproductive options should be included in healthcare. So there's a lot of variety. So there is not one talk that will fit every system in Europe and in the world. Most of the things that I will present is coming from this recently published review in Nature Reviews Cardiology. So it's a very nice review if you would be interested in this topic and you want to read more about it. And this is a great way to look back some of the things I will present today. So first start with the complex genetic background of cardiomyopathies. So in the ideal situation, it would be this. A plus indicates the presence of a genetic variant and a minus the absence. When there is complete penetrance, everyone with the genetic variant also developed the disease. However, when there is incomplete penetrance, you also have some individuals which carry the genetic variant but don't develop the cardiac disease. So they remain healthy. On the other side, we also have families that we know where there are multiple people with dilated cardiomyopathy in one family, but with genetic testing, we don't find one genetic cause. And if we put this in a nice figure, it would look something like this. So let me take here you can see complete penetrance, then the presence of a genetic variant is sufficient to reach the threshold of disease. However, with incomplete penetrance, you have in red the pathogenic variant that is detected, but probably there are some polygenic risks, so additional small variants that are necessary to come to the threshold to develop disease. And in these families, in some families, we don't find a genetic and monogenic cause. It's possible that it's all polygenic risk, so the sum of a lot of intermediate variants, but it could also be still a possibility that there are some monogenic variants that we don't know yet. But for now, I will mainly focus on these patients. So because this is the situation of cardiomyopathy, we do find monogenic causes, but it doesn't explain the whole picture. Briefly, the reproductive options that we discuss with patients. And one is pre-implantation genetic testing. That will also be the main topic of my talk in the further slides, so we'll come back to that later. Of course, there's always a possibility for patients to just have a spontaneous pregnancy and, as we sometimes call it, just take the gamble, 50% chance that a genetic variant is passed on to offspring. There is a possibility to combine a spontaneous pregnancy with prenatal diagnosis. That means that you will perform invasive diagnostics of the fetus during the pregnancy. So you can test for the presence of the genetic variant during the pregnancy. It's always difficult because then the pregnant couple has to decide what they will do with that information. And then there are still two options. One is gamete donation, so that one of the gametes or is coming from a healthy donor, and the other one is coming from the parent without a genetic mutation. And there is also an option for adoption. But the last two, yeah, we always offer them, but those are of course the least attractive for couples who usually wants to have a full biological child. Then to zoom a bit further on pre-implantation genetic testing. So what the concept is that you have a couple where one of them has a cardiac genetic disease, so we know what the monogenic etiology is. Then we would need sperm cells and oocytes of the male and female, and in vitro fertilization, so it's more of the creating embryo in the lab is the first step. Then the embryo will grow in the lab, and at a certain stage, at the blastocyst stage of the embryo, we will take one biopsy of the embryo in which we isolate the DNA and perform genetic testing for the presence of the genetic variant. This is very challenging. This is very different compared to taking blood samples of a patient, isolating DNA and performing genetic testing, because we're talking about 1 or 2 cells we get from an embryo, which is only a couple of cells. So the challenges are that we have very low amounts of DNA because we don't have that many cells we can isolate the DNA from. So we can't just test for the genetic variant. We have to do a more elaborate test to find if the genetic variation is present. The other thing, at the embryonic stage, there's a lot of genetic recombination going on. And as a reminder, genetic recombination is that some part of the chromosomes, we have 2 copies of every, switch from chromosome. And this is very difficult because the mutation can jump from one chromosome to another chromosome. And of course, you don't want to say that the mutation is not present, but it just is on a different location. How the technical analysis looks like is, I won't go into everything of this, but we always need to develop a specific test for a couple because we're talking about very few amounts of DNA of only coming from a couple of cells. So we can't test the specific mutation, but we can test the SNPs in a region of interest. So if we zoom in on that, then you can see here also the recombination already going on. You have here in red and blue, those are specific chromosomes. So here you can see that this blue part comes from a different chromosome, and this was a phase of genetic recombination. Also here there was recombination in this embryo, and here there was genetic recombination in this embryo. But on this specific point, that's where the genetic variant is. In this case, it's a PKP2 mutation. And it's lying on the, if we look at the haplotype, it's lying on the dark blue part. So here, due to genetic recombination, the part where the genetic variant is recombined to a different part. So in this specific location, the mutation is not present because it's coming from the haplotype of the unaffected chromosome. So this embryo is not affected. This is completely the correct haplotype, so this is not affected. But here you can see two that is dark blue. So these are two regions where the genetic variant is present. So these two embryos, although there was genetic recombination, still the genetic variant is present.
Job, your pointer disappeared. Sorry to interrupt. Your pointer has disappeared.
Oh, yeah, I see. I was... But the bottom two ones, those are affected embryos, and these will not be used to transfer back for a pregnancy. Then one important topic I already talked about that in the introduction are the disparities in access to pre-implantation genetic testing. Because financial reimbursement, on average, one PGT trajectory costs about $10,000 to $25,000. So it's quite expensive. Financial reimbursement really differs per country. There are different financial systems. In the Netherlands, we are quite lucky that it's included in basic health insurance. So most couples just have access to PGT when a severe genetic disease is diagnosed. But this differs in every country in Europe and around the world. Then, of course, there is diversity in how PGT is regulated in countries. There are a lot of differences. In the Netherlands, we have one PGT center, and that's in Maastricht. We are the only center that is allowed to perform PGT. So it's very strictly regulated, and it's only allowed for very severe and high penetrant diseases. But also in a lot of countries, there can be cultural and religious viewpoints that will have influence if PGT is an option. These viewpoints can come from patients, but can also come from governments or from the people that make the policies. And this also creates large disparities among countries. The last important thing is the lack of ancestral diversity in genomic reference databases. Because the entrance for an option of PGT is the finding of a genetic variant. But of course, if your specific ancestral diversity is not covered in genomic reference databases, you have less chance that a genetic variant is detected in your DNA. So a lot of genomic reference databases are coming from large registries of European American people. So the chance that a pathogenic variant is detected in those patients is way higher compared to others. So in this table, for 5 countries, and we summarized a bit how the differences are already if countries are lying next to each other. For example, the Netherlands and Belgium, we are neighbor countries, but how PGT is organized and how the financial reimbursement is already completely different. So for every country, it is very good to know what the policies and how the financial reimbursement is per country. And another really important topic is that this is really important for patients. This is offering options that patients can choose for, but they have to know what are the pros and cons and what are the benefits and specific, what are the individual benefits. So, of course, the regulatory and practical considerations are very important. Those are related to what I just told. But this is a very nice study from the group of Jodie Inglis coming from Australia. They really looked into what drives patients in choosing for pre-implantation genetic testing. And the most important thing are the experiences. So the experience in families, the psychological burden. some patients say if PGT is not an option, then I don't want any children. So taking these things, get a picture of how the patient thinks about it, is really important, taking that into consideration and if this is a good option or not. So these are a couple of key points coming from this study, which is really important to take into account when discussing these options with a patient. Then we try to summarize the whole PGT procedure from start to end. So starting at the top here, it starts with finding a pathogenic or likely pathogenic variant causal for the cardiac disease. If a patient has an active wish to have a child, wait, let me get the pointer again. Then it's really important that the couple has an intake with a genetic counselor that has expertise on this topic, because there are a lot of things that need to be discussed, and that also needs to be knowledge about what is possible in a specific country. When they eventually choose for PGT, it's very important to get a detailed family pedigree, because I started with the technical aspect. The technical aspect is usually only possible when the parents of the patient are still alive, because determining the phasing of the variant, so the genetic recombination, we also need blood from the parents to see where the genetic variant is. If that's not the case, then it's still possible, but it will be way more complicated, and an adjustment of the technical protocol needs to be made, which takes way more time. On the other side, there's the clinical aspect. As you can see on the second thing is what I just discussed. The psychological burden and experience of the patients are really important to take into account if this is a good fit for a patient. But the other thing is what I started with, the complex genetic background of cardiomyopathies. So estimating the disease penetrance in the family is very difficult, but also very important. And for that, we published a study in the beginning of this year where we tried to catch that penetrance and the risk for offspring and decision-making for PGT. So also included in this paper, one interesting finding was that the active wish of patients to opt for PGT is really increasing. That has to do that patients are demanding more options. So, and this is really an option that's almost a treatment option. For 2023, we're already way higher again, so it's really steeply increasing. And the guidelines are more and more including PGT as an option in the recommendations to discuss this with patients. But the guideline that, or the idea that we came up with, because in the Netherlands, PGT for cardiac diseases is only allowed when there is a high penetrance and high severity of disease. Usually it is always based on a discussion of experts, but we try to make an objective system to quantify penetrance and severity of disease in a family. So the first thing is to estimate the severity of disease in the patient itself. And the next thing, coming to penetrance, is to estimate the penetrance and severity of the disease in the family. And in the end, you get a specific score, and that gives you a feeling about how high the disease expression and penetrance is in a family. So to give an example, this is a female who developed a dilated cardiomyopathy at the age of 29 years old with a pathogenic troponin T2 mutation. Now, if we fill in the information of this pedigree, and we say age of onset is below 30 years old, she has an ICD implanted. And if you look in the family, there is her mother and a cousin, both are affected and also at relative young age. And in the end, if we calculate everything, then we would say that in this family, there is definitely a high disease expression and penetrance. And then this would fulfill the criteria in the Netherlands that PGT would be indicated because of the demand of severity of disease is fulfilled. To continue in this flow diagram, so after the clinical aspect and the technical aspect are both possible, and there is a sufficient reduction of risk because the penetrance and severity is high in the family, then of course PGT is always connected with an in vitro fertilization trajectory, so an IVF trajectory. So it's important that the female is also that she can go into a fertility treatment. But if this all is successful, then the oocytes can be harvested after an IVF trajectory. Embryos will be created in the lab, and then biopsies will be taken. And then depending on the selection, so some embryos without the variant, they are suitable to be transferred back for a potential pregnancy. And at this moment, after transplanting back an embryo, the chance of a successful pregnancy is 25 to 30%. So if you look here, that usually you have about 45 embryos after an IVF treatment. Some of them will be, maybe 1, 2 will be suitable for transferring because they don't have the familial variant. And then the risk or the chance on a successful pregnancy is 25 to 30%. So this also shows that the whole trajectory, it's quite laborious, it's quite intense. It takes on average about 12 months, and it doesn't give necessarily a guarantee for pregnancy in one cycle. Then I want to end with 3 scenarios, which are even more challenging and more complicated. These are scenarios from our own experience. So this is a couple where both the male and the female have a pathogenic myosin heavy chain 7 variant. The male is really severe affected with a severe dilated cardiomyopathy, and the mother, the female, she only has a left ventricular dilatation without any systolic dysfunction. Well, they come for PGT intake. But if we then go back through the steps, the most important thing is here the embryo selection. Because now you have a pathogenic variant coming from the father and from the mother. And of course, if both variants are there, then you have a severely affected embryo. And of course, we won't place them back. But in this case, we have 7 embryos. And there is only 1 embryo that doesn't have both variants. So of course, we will place this embryo back the first. But there's only a chance of 25 to 30% that will lead to a successful pregnancy. So the question is, if it's not a successful pregnancy, what will we do afterwards? Are we going to place back one of the embryos that are heterozygous? Because the female only has a mild phenotype. Do we place embryo 2 and 7 back? It increases the chance of getting a successful pregnancy, but you're introducing, again, a genetic risk. And also some of the couples, also this couple said, we would be fine. I mean, the female said, I don't have any symptoms yet. If I would get a child with having my variant, it would be fine. But the difficult thing comes in that we can't know if the embryo or the child eventually will have a comparable phenotype or maybe have a worse phenotype. Then this is also quite a challenging family, because here we saw this 34-year-old female with a severe dilated cardiomyopathy with a troponin T2 mutation. Her brother has the same variant and also developed dilated cardiomyopathy. And the mother and a cousin both have the same variant, and they don't have any phenotype. This variant is still classified as a variant of unknown significance. And that makes it even more difficult. In the Netherlands, we are not allowed to perform PGT for variants of unknown significance. But you can understand that this female, she has a severe phenotype herself with this genetic variant, and she really doesn't want that this variant is transferred to her children. But yeah, it's quite complicated, because we don't know. There are also people in the family that don't have the phenotype. So we don't know what the factors are that determined that those siblings develop a phenotype. And these are very complicated cases, and also very complicated counselings. The last scenario is about Titan. As Professor Heijmans already showed, it's quite prevalent. But we also know that Titan usually doesn't give a phenotype like in this family. So in this family, we have a young man at the age of 12 who had a heart transplantation at the age of 15. And this is very atypical for a pathogenic Titan variant. And also in the family, there are multiple patients with a Titan variant who didn't even develop a phenotype. So coming back to my first figure again, probably in this patient there is more going on than only the Titan variant, and this is something that we can't put a finger on right now. But it's very difficult because this is a person with a severe phenotype, already had a heart transplantation, and now wants to have children and really doesn't want that his child will have the same trouble as he had. But it's very, very difficult to make a decision here if this would be a suitable candidate for PGT. I have one slide about future possibilities, because it would be great in the future if we can determine the polygenic risk, so that we know better of the embryos what the differences are. We are going into the era of genome editing. How great would it be if we have embryos and we can just edit the variant out so there are more embryos suitable to place back? There are increased possibilities to determine the risk reduction and who will benefit the most from PGT, which patients and which couples do benefit the most. And the technical innovations keep going on. And now we have to take biopsies of the embryos, but there is already research in a quite advanced stage that we now can perform genetic testing in the medium that an embryo is in, so we don't have to take biopsies anymore. And those are some great technological advances. So the key points, I have to say this is the worst slide I ever made because it's completely filled with text, but I just wanted to put the key points on one slide. So the one thing, the genetic architecture of cardiomyopathy is complex. It's not a monogenic disease. PGT is an option for, is a good option for couples with a genetic variant who wants to have biological children. But genetic counseling is crucial because it's a very laborious and complex procedure. So, and the perspective of the patient is really important in this, but also the possibilities from the healthcare side. There are major differences among countries. So discussing the possibilities, it's really essential to know what are the possibilities in the country that you're in. If a couple goes for PGT, medical and family history is very important to determine the eventual risk reduction. And finally, keep in mind, PGT is not something that you go into and next month you're pregnant and it goes. It's a very laborious process and on average takes about 12 months. Well, thank you for your attention.
Thank you very much, Jacques, for this beautiful talk. Indeed, we are in an era that is able to discuss these various options. So it's very important to be able to discuss this, which will increase more and more coming from the patients who want to discuss this. In fact, the decision about these options are not so easy for the reasons you explain, medical issues, religious issues, economic issues, but also legal issues from the country. So, for example, in France, it is authorized only in case the disease is expected to be very serious in the child and without any therapeutic resources for the child.
Yeah.
So in fact, we have in France only case-by-case discussion because of that. So I would like to ask you, what is the legal context in Netherlands, and what is the proportion of requirement from patients that are at the end accepted by the medical center?
Yeah, those are some good points. And what you described, it's the same system in the Netherlands. So we also have a case-by-case discussion because PGT is only allowed for severe diseases with a high penetrance. But we do take into account more and more the perception of the patient and the psychological burden. And we also weigh that into, if it's allowed or not. What we have at the moment, because it is now a case-by-case discussion, officially cardiomyopathy is not an indication for PGT in the Netherlands, except unless there is a reason why it should be accepted, so as high severity. And because it's not really an option, or not a real possibility, you already see that there is a bias in patients who opt for PGT. So the couples that we see at the moment, these are really the severe cases, that looked into options and looked into possibilities, and then eventually came to PGT. At the moment, about 95% of the couples that we see is eventually approved for PGT.
Okay, thank you. I see there is no additional question from the chat. Just to underline the fact that, as you said, it is very important also to have a pre-conception discussion with the patients, probably to inform them about these possibilities, to discuss about all the options that are quite various in the context of inherited cardiac disease. So how do you say these issues to the patients you see in consultation before the pregnancy? Do you inform the young adults about coming back to discuss pregnancy quite early when the project is mature, or how do you discuss about these reproductive issues with the patients in practice?
Yeah, at the moment, after genetic etiology is detected, at this point, it's a standard sentence or letter to the patient. So we send a letter to the patient with the result, and we already have a standard sentence in there that are reproductive options. And if someone wants to know more about that, they can be referred to a genetic counselor at our center who specialized into pre-implantation genetic testing to talk about the options and the possibilities. So, and I think that's something that we already reach a lot of patients with, but I think the awareness is still not that high. And in the Netherlands, that's because it's not an official indication yet. At the moment, we are in discussion with our national governance to at least change it for some genes. Because for some genes, we say the severity and the penetrance is so high, this just should be an indication for PGT. So, and if that would be agreed, then we also have more formal and legal base to reach out to patients to talk about these possibilities.
And we have the similar meaning in France too, and especially because in France the legal issue is the same for prenatal diagnosis and for pre-implantation diagnosis. Or I think we could have a different way to think about because prenatal diagnosis is not the same as pre-implantation from the point of view of psychological issues and religious issues and so on. So probably there should be some evolution from the legal aspects also from this. Do you perform also some prenatal diagnosis sometimes or not?
Well, we're now writing a book chapter on reproductive options. So we also had this question in mind. So we asked all the centers in the Netherlands if they ever performed prenatal diagnosis for inherited cardiac disease. And no one ever did that. Maybe 1 or 2 cases were described. And I also can imagine it because it's usually when we offer prenatal, so that's the couple is already pregnant and we offer prenatal testing, and usually it's with the idea that if the genetic variant is present, they have the opportunity to terminate the pregnancy. But it's very difficult talking about genetic heart disease, and you don't know actually what to expect because how the severity of the child will be. And the next step would even be, but we were never even there, if there would be a gynecologist that would do pregnancy termination for this indication. So I think that's even more complicated than pre-implantation genetic testing.
Furthermore, I suppose that those patients do have received the counseling before actually getting pregnant, so they must have gone through lots of information and lots of hard decisions that probably is very emotionally difficult to undo, I suppose. So yes, I can see the difficulties in there. May I ask you very briefly, where the majority of those referrals come from? Specialized centers, obstetric center, cardiomyopathy center? What is the source of the referral?
Most of the referrals are coming from a clinical geneticist. So the clinical geneticist diagnoses the genetic etiology, discusses the option, and then refers to the PGT center. I think about 2/3 of our referrals is clinical genetics, and the others is mostly coming from cardiologists, and almost all from academic centers.
So cardiomyopathy patient already been genotyped and then eventually go through the decision pregnancy and therefore will be sent back to you, right?
Yeah.
Yeah. Thank you very much.
Okay, so I think we can close this webinar. Very interesting, very important issue in the field of inherited cardiac disease. So I would like to thank our two experts. I would like to thank Teresa and Nimke, of course. So we can stop here, and you will be able to have other webinars from the ERN in the near future. So thank you very much for this moment together.
And thank you, Philippe, of course, as well.